current talk, he will give us some insight on how delayed childbearing paradoxically contributes to the multiple birth epidemic we see in the US and also in Europe.
Thank you very much, Professor Weghofer and Professor Blumenfeld. Thank you very much. Thank you, ladies and gentlemen. I guess I should refer to you as survivors at this point in the day. So thank you for not leaving me here entirely alone on stage. The subject matter of today is based on a paper we published last year in the journal Obstetrics and Gynecology, which was titled Delayed Childbearing as a Growing, Previously Unrecognized Contributor to the National Plural Birth Excess. And it is true of any piece of work, there is a story behind this project. And it goes back to one of our fellows that was in training sometime during the 90s, during which time the fellowship training duration was 3 years altogether. Upon successfully completing his training, he departed for his future parent institution with 3 children in tow. Fast forward to 2012, when he invites me to speak at his parent institution, only to find out that at this point he is the proud father of 6 children. Being a reproductive endocrinologist, I asked him, of course, was IVF involved? Did he embark on superovulation IUI to achieve this feat? And the answer was none of the above. This was a spontaneous conception. His wife was around 35, 36 years of age, and they ended up with triplets. And you hear this story when you really begin to listen from many friends and colleagues who all they want to accomplish is round up the family, maybe have one more girl or just one more boy to make the family perfect. But if you embark on that assignment in your mid-30s or beyond, you run the risk of expanding your family, not necessarily just rounding it up. And that's the subject matter of today's conversation. I should add that, as is true of almost anything, there is nothing new under the sun. This phenomenon has been known for a very long time. We were able to go as far back as 1865, which may not be as far back as is feasible, and find a paper in the Edinburgh Medical Journal by J. Matthews Duncan titled On the Comparative Frequency of Twin Bearing in Different Pregnancies, wherein the key phrase is, quote, twin bearing increased with the mother's age. Turns out that there is a substantial literature out there that we tend to miss or maybe have overlooked, and that includes myself. For example, a body of work by Professor Balmer, who was at the University of Manchester, who published extensively on the subject. This particular paper having been published in 1959 in the Annals of Human Genetics, wherein the figure he displays says it all. Essentially, when you plot twin maternities per 1,000 maternities as a function of the age of the mother in years, you can tell from the unimodal curve that he displays that the risk of twinning increases in an age-dependent fashion, appears more or less to peak around age 35, and then declines gradually thereafter, presumably because fertility is on the decline at this point. Equally important is the observation that none of that is true for monozygotic twins. In other words, we are talking about multiple ovulations for reasons we do not fully understand, but which we can speculate about if you would like later on, if time permits. And so it occurred to us, since delayed childbearing is a sign of our times, it occurred to us that maybe delayed childbearing, a phenomenon that was already known but not discussed in this context, could be yet another ingredient of the national plural birth excess, in this case in the United States, but of course potentially anywhere else. According to this view, the national plural birth excess here or anywhere else would therefore comprise the contribution of iatrogenic forces, which we are all familiar with, whether it's IVF, ovulation induction, or superovulation, generally with intrauterine insemination, and, in keeping with our discussion today, demographic forces, that is to say, delayed childbearing, which is currently on the upswing, certainly in the United States. Some have referred to the national plural birth excess in the United States as an epidemic. There was, in fact, Dr. Alan Templeton from Aberdeen in Scotland. He didn't exactly mean, of course, to connote an infectious process. He meant to connote, of course, the magnitude of the phenomenon. And the magnitude of the phenomenon is mind-numbing. In 1998, which was the height of the epidemic in the United States, some stunning numbers were encountered. At that time, 27% of twin infants born in the United States, roughly 30,000 out of 111,000, were deemed iatrogenic in origin, that is to say, man-made. Even more alarmingly, 84% of higher-order infants born in the United States in 1998, roughly 6,400 out of 7,600 total, were deemed iatrogenic in origin. And if that was not enough, in 1998, we did 627 quintuplets, even though spontaneously occurring quintuplets would have been expected at the rate of 6 or so that year, and 79 quintuplets, even though, given the 4 million babies born in the United States, give or take, we would have expected 1 or 2 spontaneous quintuplets that year. And so in 1998, we were clearly at the nadir in terms of our controlling the multiple birth excess in the United States. I will digress for a moment and ask if any of you is familiar with the notion of a never event. That's a notion deployed in the United States in the context of hospital accreditation. When a patient is operated on the wrong side, it's referred to as a never event. When the wrong patient is operated on, that too is, of course, a never event. Or when we leave instruments behind in a bodily cavity, that's viewed as a never event. Those are reportable events, mandatorily reported events, that have significant effect on the accreditation of healthcare facilities. I'd like to suggest, at least for discussion, that in 2019, certainly, a quadruplet or a quintuplet in the context of fertility promotion should be a never event. We certainly cannot tolerate the kind of numbers we saw at that time. That said, we have gained some ground since then, and I'll show you the data, but much remains to be done. In a way, this is all due to a good thing. 50 years of fertility promotion essentially were marked in 2017. By that I mean 50 years since the approval of clomiphene citrate by the FDA, and 3 years later, the approval of human menopausal gonadotropins. In 1981, IVF arrived at the American shores, and in 1987, Dodson and Associates introduced the practice of superovulation and IUI to the United States. And so when we look at the totality of multiples in the United States, it represents, from an iatrogenic point of view, a combination of ovulation induction, IVF, and superovulation and IUI. Delayed childbearing is the latest arrival on the scene. And the numbers are very clear. Interestingly, if you actually look up the literature, there is very little mention of delayed childbearing in the literature until 1984, which is when the first paper saw press. It's defined as childbirth at age 35 or older, and is invariably associated with diminished fertility, of course, at that period in life. And if you do succeed in conceiving, is associated with a high-risk gestation. The numbers are crystal clear. If you look at the vital statistics data of the United States between 1949 and 1966, it's readily apparent that most women gave birth under age 30. Fewer women gave birth between age 30 and 40, and very few women gave birth over the age of 40. And the same held true for white and black women alike. If you now look at the same database for the years 1971 to 2016, it becomes clearly apparent that fewer and fewer women who are less than 30 years of age are giving birth, and more women who are 30 to 40 years of age are giving birth. It is still rare for women over the age of 40 to give birth. Here again, the numbers hold true for both black and white women alike. Keeping that in mind, let us now take a look at the various factors that comprise the national multiple birth excess, essentially IVF, non-IVF, and I'm going to add into that delayed childbearing. But to begin with, here are the total numbers over the last 50 years. We are looking here at the national twin birth rate as it progressed from 1967 to 2017. That is to say, since Clomid was introduced to the latest year for which data are nationally available. We are talking about a 1.9-fold overall increase in the national twin birth rate, a mean growth rate of about 1.7% per year, and a 2014 rate that was at an all-time high and more or less stayed there. We are in a plateau at this time in the United States. There are sometimes indications that we might be turning the curve down, but it hasn't happened yet. The 2017 rate represented a 0.3% decline, but that was not statistically significant. When it comes to the higher order birth in the United States, the national higher order birth rate increased by 6.7-fold to a 1998 high, and then declined by 47% from 1998 to 2017. There was a small decrease from 2016 to 2017, but that too was not statistically significant, which begins to worry some of us who feel that maybe we are entering another plateau and that the progress we have witnessed thus far may in fact be attenuated. Still, even if you look at the current state of affairs, that still leaves us 3.5-fold in excess of where we were in 1967. Apart and distinct from all of these numbers, it is still stunning to me that in 2017 we still featured 193 quadruplets and 49 quintuplets and higher order. Again, with numbers that would have predicted one or two of those if they were spontaneous in nature. You might say the trend is moving in the right direction, and I would agree with that, but there are some concerns that we may be plateauing yet again, and that we need to double our efforts to continue the progress we have made so far. IVF is probably where most of the progress has been made. If you look at the higher order rate in terms of IVF birth order rates, it decreased by 92% from 1997 to 2017 to a point where only 1% of all IVF births in the United States are of the high order variety. At the same time, singleton birth in the United States increased 59% due to IVF, which they now constitute 69% of all IVF births. Twins have decreased by 30%, such that they now constitute 30% of all IVF births in the US. This is a significant and noteworthy improvement, although it's useful to recall that the singleton rate, of course, in the population at large is closer to 98%, not 69%, and the incidence of twins in the population at large is closer to 2% than to 30%. All of that, of course, is attributable to the number of embryos transfers, and those numbers largely correspond to the number of births we just discussed. The number of 3+ embryo transfers decreased from 83% to 6% from 1997 to 2017. The number of double embryo transfers increased correspondingly from 12 to 39%, although those numbers are now on the decline. And the number of single embryo transfers increased from 5 to 55%, which is a big change, although the elective single embryo transfers under that rubric only went up as high as 31%. Non-IVF related multiple birth, however, for which we don't have a registry and therefore we have to impute, mostly by subtraction from the total, have not made significant progress, and to my mind constitute the leading challenge we have going forward in terms of further reducing the fertility-induced multiples. If you look at the twin birth rate fractions that comprise IVF, non-IVF, that is to say ovulation induction and ovarian stimulation, and then the remaining of the twin birth rate would be spontaneous, you can see that we are pretty much stationary when it comes to ovulation induction and ovarian stimulation. This is even more striking when you look at the higher order birth rate, wherein IVF is showing significant progress, but ovulation induction and ovarian stimulation appears to be holding steady. Seems to me that as we go forward, that should be a major emphasis of our professional associations, and of course, every single practitioner should keep that in mind. I conclude this section by saying that IVF no longer leads the multiple birth excess in the US. Since 1997, IVF was not the leading contributor of twin infants, and since 2004, IVF was not the leading contributor of higher order infants. Lastly, let me say something about delayed childbearing as the new kid on the block and the new contributor to the multiple birth epidemic. if you look at the national vital statistic data of the United States from 1949 to 1966, that is to say, before any fertility-promoting therapy was available, you observe the same unimodal curve that I showed earlier from the work of Balmer, wherein if you plot unassisted plural birth rate as a function of maternal age at birth, you see a rising curve that peaks at around age 35 and then declines thereafter. Eyeballing the data, you would say that the risk for unassisted plural birth in white women would go up by a factor of about threefold when they reach age 30 to 35 or 35 to 39. And for black women, that factor might be a fourfold increase compared to their white counterparts. In the table that we constructed in the paper, which provides more accurate numerical data, you can tell that for women 35 to 39 years of age, the risk of having a twin birth goes up by a factor of 2.5, and for black women by a factor of 2.7. The risk of high-order birth for women aged 35 to 39 goes by a factor of 4.6 for white women and 6.4-fold for black counterparts. We then use these data to try and create a composite of the factors that account for the national plural birth excess in the United States. And using those calculations, we find that in white women, delayed childbearing in 2016 accounted for 24% of the national plural birth excess. And for black women, the corresponding figure was 38%. If we then simulate and extend the projections to 2025, using multiple assumptions that could well be wrong and or change along the way, but subject to those limitations, if those assumptions are indeed correct, delayed childbearing by 2025 could potentially account for 46% of the national plural birth excess in white women and 40% in their black counterparts. So as we go back to where we started, we would like to suggest that today, as we think about the national plural birth excess, we don't simply focus solely on the iatrogenic forces, IVF, ovulation induction, and superovulation, but that we take into account what is a major demographic, social phenomenon, probably worldwide, which we refer to as delayed childbearing. In the spirit of ending on a more cheerful note, I'd like to quote something that Mark Twain wrote in 1879 in what was known to be his baby speech, wherein he said, "Sufficient unto the day is one baby. As long as you are in your right mind, don't you ever pray for twins. Twins amount to a permanent riot, and there ain't any real difference between triplets and an insurrection." Thank you very much.
Thank you, Professor Adashi. Very illuminating talk.
Thank you.
Is the explanation for increased spontaneous multiple pregnancy in the high age is just because the increased FSH level, or any other explanations?
So the truth is, the question I think was, what's behind this phenomenon? And I'm afraid we don't really have evidentiary information. I think it is reasonable to speculate that the fine-tuned mechanism that generally are responsible for the generation of a single dominant follicle begin to fray as women age, and they are no longer perhaps quite as precise and quite as effective in assuring that only a single ovulation occurs. And so as we proceed, increasingly, presumably, multiple spontaneous ovulation will occur in that the fine-tuned mechanism that guarantee a single dominant follicle emerging may no longer be operational. It's entirely possible, though, that some of that is contributed to by variable or varying levels of FSH or other factors that potentially could be behind it. But the bottom line is I'm standing here speculating because we really don't have any relevant evidentiary information that explains this phenomenon. We can tell, of course, that there's nothing new here that's been known long ago to occur, well over 100 years ago, of course. And in fact, I'm reminded that if you look up the church records in Europe or in the United States, where the birth records have been so meticulously documented, you'll see the very same findings. And that has, of course, at the time had a lot to do with the fact that women did not have the benefit of contraception and simply conceived year after year after year. And so you could observe women into their late 30s and document that the longer they went about having children, the more likely they were to produce multiples. These days, of course, it's very different. The notion of having a delayed childbearing is preceded by a long period of contraception. And only when a woman discontinues contraception with an eye towards conceiving, this underlying phenomenon is exposed. But evidently, that is a phenomenon that in all likelihood is as old as humanity, although we can only speculate on that.
But wouldn't it also be possible that part of the story is Clomid related? That Clomid is, taken more often and not as closely monitored as we monitor our IVF patients?
Well, I think that's a fair question. In other words, what data do we have on the